Good afternoon, ladies and gentlemen. I'm Thomas Chumpin Cai. It's my honor to be here. Today, my topic is manage a traumatic cataract with zonulopathy. We could start with a short history of trauma or prior vitrectomy. The stadium examination can show instability of the capsular bag complex by pupil size, pseudo-exfoliation material, change in lens position with movement of patient, iris transstimulation defect, depth of the anterior chamber, space between iris and anterior capsule wider on one side. This patient had a history of trauma at her left eye. The anterior chamber angle shows asymmetry. It's shallow at temporal side. Sometimes they may be presented as acute angle closure glaucoma. Lens tilting can be detected at anterior segment OCT or flex before cataract surgery. During the surgery, there are several markers to suggest zonal weakness, such as anterior capsule wrinkles, posterior capsule flutter, or posterior capsule radial striae, and crescent sign. We can use capsule dye to clearly visualize the capsule, and use flex or Zepto to do capsulotomy at the center of the lens. Iris hooks and capsular hooks can be used to stabilize and center the lens complex. Capsular hooks are longer and larger than iris hooks. Capsular hooks can catch the equator of the capsular bag rather than the capsular rhexis margin. Capsular tension ring or cement is a good choice to stabilize and center the lens complex. The timing of using capsular tension ring is as late as possible to minimize capture the cortex. There is anticipated risk in the presence of zonal weakness, such as posterior capsule rupture, lens dislocation or decentration, vitreous loss. This is a 59-year-old male patient. He had a blunt trauma history of his right eye about 1 year ago. His visual acuity was 1/60 of his right eye, and the refraction data was error due to dense cataract. Stadium examination showed deformity of pupil, nuclear cirrhosis with dense posterior subcapsular opacity. There is no focal donesis. The anterior chamber depth is 3.23 mm. It's deeper than his left eye. There is no lens tilting at anterior segment OCT. Next is his cataract surgery video. Femtosecond laser had advantage in zonal dialysis case. The anterior capsulotomy can be central as possible with a 5 mm size. It can be stabilized with iris hooks or capsular hooks. When I was doing hybridization, I found it is difficult to rotate the nucleus and there is a crescent sign noted at nasal area. This is suggest zonal dialysis at nasal area. I should use low parameter focal emulsification, low IOP, low flow rate, and low vacuum to remove the nucleus. I prefer stop and chop technique. After scalping, I divide the nucleus. I found the nucleus is sinking. Now I have 3 options. First, use iris hooks or capsular hooks. Second, use capsular tension ring. Or continue emulsification. I don't have capsular hooks in my hand, so I decide to use iris retractor. I fill the anterior chamber and subcapsular area with OVD. I use 2 iris retractor to capture the capsule at nasal area. The iris retractor is behaved as artificial zonules. It provides a counter force. I keep focal tip in central safety zone. Minimize force on dialysis zonules. More stable and efficiency through this system is important to manage zonal dialysis case. Perform focal emulsification smoothly in the first 2 quadrants. Elevate IOP from 40 to 50 mm mercury for the last 2 quadrants to minimize capsule bag distortion. There is posterior capsule flutter noted at weak zonules area. During focal emulsification, there is excellent flowability. That means vitreous is not clogging in the focal tip. After remove the cortical material, I fill the capsule bag with OVD for capsular tension ring insertion. The timing of capsular tension ring is as soon as you need, as late as possible. I use the only capsular tension ring without scalene fixation for this patient. If mozonials lose integrity in the future, it's easy to suture on scleral through Sioni ring. The eyelid was dialed to the site of dialysis. I insist on using monofocal idol to minimize impact of idol tilting and decentration. However, zonial dialysis was worse than it looks. My vitreous prolapse noted after I removed OBD. Higher cutting rate and low flow by manual anterior vitrectomy was done. Milestay was injected to control the pupil at the end. This is the anterior segment OCT by Aeromeister 700. Although this patient has trauma history with compromised zonials, the idol is well-centered with capsular tension ring. His visual acuity after surgery is 6/6 of his right eye, and his auto-refraction data is great. Thank you for your attention.